and it worked. I don't know what I'm going to do with that file, but okay, so here we go. I'm going to share again. And welcome to CAT class. So the little bit of upcoming stuff going on. Of course, we got Dr. Kuehl today, but tomorrow we're going to have Dr. Crystal Bowles. She's here, the shorter one in the picture, and that's Dr. Rongren on the other side, and of course me in the middle. That's a few years ago when they were, hi Kirsten, sorry to embarrass you.
That's okay, it wouldn't let me into the meeting. I was trying.
Oh, really?
Yeah, huh. You guys are just too popular, I guess.
Nerve. So Crystal worked for me before she got into vet school, and then she's done 2 internships, one of them an optho internship out of Portland, and now she's optho resident, and she's super smart, super talented. She's a fantastic human, and she's been doing a lot of presentations lately in that role, and so I'm really, really excited to hear what she has for us tomorrow, and it's going to be conjunctival and corneal diseases, and that's what you're going to see a lot of, and hopefully she can teach us how to not refer these to her and tackle them ourselves. So I'm going to stop sharing now and try to get into my other board meeting, and Dr. Kuehl is going to take it over. I don't know how we became friends, but it's been a couple of years now since you've been here in the great state of Washington. She is a dear friend and somebody I rely on a lot for a lot of different things in a lot of different venues, from access to care issues to shelter issues to what we should take camping and hiking issues. Oh, hi Dana.
Hi.
And hi Jackie. And so I'm really, really excited to have her talk today and share all her wisdom on things you're going to see in, hi Sarah, on neuter and spay issues that you'll confront. So take it away, Dr. Kuehl.
Okay. Well, actually, guys, but I'm really excited because I've been going through teaching withdrawal in the last couple of weeks. So really excited when Dr. Marshall suggested that I join this group and share some knowledge with you. So let's go for it. If you've been through rotation at Seattle Humane Society, we might have gone through this before, but maybe you've had some experiences since then that can add some perspective. So if you have questions that come up, of course, throw them in the chat, and Christina is going to help us with that. And yeah, let's go for it. Okay. So yeah, I'm a clinical instructor for Washington State University, and finding myself studentless in this time, which is a little sad, but hopefully I'm able to share some knowledge.
Cougs. Yeah.
Yeah, go Cougs. Uh-oh. Come on, you gotta work. Oh, now it's gonna work. Okay, great. So if you need to get a hold of me, you've got burning questions after this lecture, here's my email. I'm on Insta. You can follow me and see my cat pictures. I love mentoring students, and I started out my career as a shelter veterinarian and as a high-quality, high-volume spay-neuter surgeon. So I really like being able to take all of the things that I've learned from those experiences and pass as students, and also to my workers, to my colleagues. I'm also really passionate, as Dr. Marshall said, about access to care issues. And if you've been on the rotation, you know that we're pretty active in outreach for the community here in Seattle, specifically trying to serve people who are experiencing homelessness or at risk of homelessness, but have pets as support animals or sometimes service animals. And yeah, I love volunteering. I'm also, when I'm not being a veterinarian, obviously an outdoor enthusiast. Find me on Lake Washington most summer nights on my little sailboat, hiking around in the mountains. I think sailing is still social distancing, so I don't think I'm going to stop myself from doing that as long as the weather cooperates, but we'll see. And definitely 100% a Leo. And these are my boys here. I just have to focus on them for 1 second because they're so darn cute. That's surface and tripod, who Dr. Martin knows well. All right, why should you care what I have to say to you? Well, I have spayed a lot of cats. If there's one thing I feel really confident about doing, it's spaying cats. I'm perfectly happy to admit there's lots of other things in veterinary medicine that I might not be very skilled at or experienced with, but this thing I am. And I realized that surgery can be really difficult for students, especially you lovely type A personalities, because you want there to be one right way to do things. And in surgery, there's a lot of right ways to do things. And different people are gonna have different techniques or approaches that are gonna work best for them. And I think especially if you're just starting out as a surgeon, it's good to keep an open mind. I think especially in surgery, for whatever reason, there's this whole, well, that's the way it's always been done mentality. And I find that very frustrating. And I don't know if anybody else has encountered that as well. But we've got a lot of ways that things can be done that are different than the way that people were taught 30 years ago. And in addition to that, we're also going to build a body of research to back up some of those techniques and choices and approaches for surgery, so that we can hopefully continue to improve our certification for veterinary students and new vets. And the last but not least, I've struggled through a lot of things, and once you struggle through things enough, you figure out what to struggle anymore. And so that's where some of these tips and tricks are coming from. Okay, so the first thing we're going to talk about is pregnancy and estrus, because you're going to run into this a lot, because cats are always in heat until they're spayed, pretty much. Not completely, but especially this time of year, you see lots of in heat cats, starting to see pregnant cats, and then some run into what I like to call in heat plus, which is usually they've had a couple and they're also they've really got a big old uterus. Afraid of these, but if you haven't encountered them before, it's going to be really different than just a standard cat. Be prepared for that. And comfortable. In private practice, you may be in a situation where you can tell an owner, well, if she's really in heat today, I picking up on exam that she's pregnant, there may be a choice not to go ahead with surgery, depending on the needs of that owner and that family. That being said, I'm sorry, well, you're seeing my screen anyway, so it doesn't matter what I look like. You can offer surgery on a pregnant or in heat animal, and you can perform a spay on an animal basically up to parturition. Now, I'm not going to like, is that okay? How do I feel about that? Because as veterinarians, we're all going to make decisions about how we feel about that and how we're going to deal with it. So I'm just going to tell you, if you end up in a situation where you're performing that surgery, here's how to do it safely. I'm hoping that during your physical exam, you might be able to pick up on some things that would let you know if an animal is in estrus or pregnant. So that might include your abdominal palpation, feeling a gravid fetus, or ping pongs or gumballs in the abdomen, which shouldn't be. In addition to the bladder, you don't want to feel the bladder and be like, it's a pregnant uterus. And then in heat, we've got some signs that cats show us, like lordosis, if you all remember. They're gonna put that little tail up in the air, meow, 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 meow. I think I have a slide of that actually. Oh yeah, that's the happy, happy cat. Really wants you to examine it. You know, some cats are like that normally, but especially this time of year, I'm gonna be suspect that that really vocal cat that's wiggling its tail all around may also be in heat. The owner might let you know as well. Cats don't really give us a lot of external signals about being pregnant or in heat. They don't get a lot of mammary development, maybe mild. They don't get enlarged vulvas like our dog friends do, and oftentimes we don't appreciate vaginal discharge when cats are in estrus either. So it may be something that you just find out once you get in there. If you do know that you're spaying a animal, you're going to want to palpate for the size of those fetuses and make sure that you make an incision that's large enough to get at least the short axis of those fetuses out of the incision. And you also want to think about patience, especially when you have an animal that's farther along,
Yeah.
big old
Washington State doing like tips on cat spay and neuters.
somebody mute their microphone. When they're farther along, you want to think about them kind of like a horse in surgery. They've got that big grab uterus and it can be pressing up on that diaphragm. And unless all of your surgeries are going to be on a ventilator, they may have a hard time with spontaneous breathing and getting good oxygenation and good breaths of anesthesia. So you can think about sort of propping up their thorax a little bit higher than their abdomen to help relieve some of that pressure of the uterus on the diaphragm. If you have a table that tilts, that's great. Or if you just have some towels that you kind of tuck up under there and make a little tilty table yourself, that works too. Increased blood supply is the main thing we're going to encounter with these gravid uteruses and these uteruses that are in estrus, or as I like to say, well used. And so if you, especially for a late term pregnancy, you may want to consider having the owner go for some additional fluid therapy during surgery to kind of support that animal as you're taking that extra blood supply out of them, more or less. And then we're going to take some steps to ligate those uterine vessels individually, the animal's safe. And I'm gonna draw a little diagram in a second because I figured out how to use the whiteboard and it's really fun. When you remove a gravid uterus, you need to keep those clamps in place. So you've got a clamp on the uterine body and you have clamps across the uterine horn, level of the proper, across the middle uterine vein bundles. And we've got some research to show us that the way of causing the fetuses to expire that results in the least fetal suffering is by taking that gravid uterus with the clamps in place and setting it aside for 45 minutes to an hour. And basically what happens is those fetuses are anesthetized. They've got the anesthesia in their system from the sheer blood supply with their mom. And then as you remove them and you clamp off their oxygen supply, they become hypoxic and they expire from hypoxia while they're still anesthetized. The very worst thing that you could possibly do with that uterus is open it to euthanize those kittens. Some people like to inject euthanasia solution through the uterine wall to euthanize, but we don't actually have research to support that that's necessary and there is still a possibility of causing fetal death that approach. And even if you're not thinking about fetal suffering, you can think about where those tissues are going to be disposed of in the world. If they're not being cremated, you're essentially taking poison and putting it out into the environment and kind of doing so unnecessarily. So I am not a fan of that technique and I don't teach that technique, but I know that a lot of people do it just because it makes them feel good. Any questions on that? Are we good?
I don't have any questions popping up now. We were just having everybody turn their cameras off because the sound was pretty patchy. Okay. I'm sure that Zoom is slammed right now. I know that everyone and their freaking mom is using it. So we just had to turn their cameras off, but the sound looks like it's much better for everybody. And so far, no questions. So just keep showing.
Okay, great.
Cat uteri.
So when animals are in estrus, we're also going to have some increased vascularity of those tissues, and then the uterus itself can kind of go through a different range of textures from being very turgid and firm and thickened to actually being very friable and likely to tear. And so you're going to have your meticulous tissue handling and you're going to have to get a sense for the tissues that you're dealing with and if that is, if you think they're going to be on the turgid end of things or the friable end of things, so that you can take appropriate steps to prevent tearing and tearing. So when animals are in heat, I do avoid using clamps on the uterine body because they can tear through the tissue so easily. But as I said, with the gravid uterus, if you've got fetuses in there, you have to place a clamp on the uterine body before you remove it from a cat, because otherwise you're going to have fetuses potentially exposed to air, and that's not going to be a good situation. Okay. So just to show you how big of a difference there can be in uterine size just from regular to being in heat, it can be massive. And that uterus on the right, that's a uterus that you could definitely be tightening your encircling ligature around and it slice right issues. In those cases, when I've got those big meaty uteruses, I like to size up my suture, and oftentimes I'll go up pretty far, like even to aught, to help prevent that sort of slicing action through there. And that's definitely a use you want to avoid nipping the uterine body if you can, because that is very likely to tear. Okay, now I'm going to try the whiteboard. So we're going to talk about ligations. Oh, where'd my whiteboard go? Do you see it? I don't see it.
Wait, I can see
There it is.
I think.
Okay.
Yep. You're good. Thanks, Hannah.
Okay.
Hannah says she can see it too.
Okay, now I have to find the control. Wow.
Proud of you,
Oh,
Kate.
there they are. Oh, whiteboard controls? Oh, uh-oh. I don't know if it's gonna work as nicely as I wanted it to. Well, that's odd. All of the whiteboard thingies. Oh, I got it. Okay. Whew. Exciting. Okay. All right. So we've got this big in-heat uterus like this. And we've bifurcation, and we've got our middle uterine artery and vein bundles kind of going crazy on the sides, right? So we make our encircling ligature here, 1 or 2, but when we remove the ovaries that are causing this uterus to be enlarged, and keep in mind, the hormonal influence on the uterus is going to be most distinct, most dramatic in pregnancy, estrus, and any sort of endometrial hyperplasia or progesterone-driven process like pyometra. So anytime we have any of the conditions, we have to consider the current size of the uterus and then what's going to happen to it when we remove that hormonal influence. Especially when we're talking about pregnancy, but also in those other situations, that uterus can change in size very rapidly, like not a couple of days, like sometimes a couple of hours. And so if we're not taking precautions to make sure that we've got good hemostasis of these middle uterine artery and veins, what's going to happen is we're going to end up with a uterus that shrinks down like this. And all of a sudden we've got this encircling ligature. It's not really doing much anymore, is it? So in this situation, what I like to do in combination with my encircling ligatures to ensure that I'm going to have good security and hemostasis of these middle uterine artery and vein bundles on the side is I like to use a transfixation technique. Now I know at WSU you guys are taught what I like to call a figure-8 transfixation. So you kind of drive your needle through the tissue and then you come around and you tie twice, and then you come to the other side and you tie 4 more times. So that's a figure-8. Now, this side of the figure-8 is doing pretty good because it doesn't have very much uterine tissue incorporated. The right side, sorry, you can't see me pointing. The right side of the figure-8 looks pretty good, and it's gonna get a good tight hold of those vessels. But the left side of the figure-8, once that uterus shrinks down, is not gonna be doing much at all. So what I actually like to do, there's a way of do. What I like to do for my transfixation is I like to just come through the very edge of the uterine tissue, come around the vessel bundle, do my 6 ties as a interrupted transfixation, and then I just do the same thing on the other side around the other vessel bundle. So they're not connected at all. I don't have extra suture looping around the uterus that's going to get loose at some point. And I like to keep that pretty close to my encircling ligature because when I go to remove the uterus, if I have my transfixations, let's see, like way up here, when I go to cut that, I'm going to have a stump. So I'm going to leave less of a tissue sphere. I want to keep my transfixations close to my encircling. Okay, so
you have a second.
Yeah.
So we have a question that says, do you always remove the uterus when spaying? What I've learned is only to remove the ovaries unless there is something very wrong with the uterus. And I maybe should have qualified with what country this person is coming from. I don't know if anywhere, any of the vet schools in the US are teaching ovariectomy, but it sounds like that's question number 1.
Cutting edge. This is a great question. So we're in the dark ages over here, and our vet students are being, what?
They're from the Netherlands. Thanks, person.
Oh, Netherlands. Excellent.
What's your name?
I love it.
Sorry, I'm afraid to pronounce it wrong. Yes, they're from the Netherlands. That's where this question is coming from.
Fantastic. I 100% agree with you. As long as there's no pathology in the uterus, so I would consider pregnancy like kind of a pathology. You want to get rid of that. But as long as there's no masses or pyometra or other problems, you can much of the uterus in there as you want. And so still a little bit in the dark over here. At WSU, the students come to me and they're told that if they have 2 lumens, when they cut their uterine body, that they fail their junior surgery, or they have to redo their ligatures on their junior surgery animal. And I am here to tell you there is nothing to back that up scientifically. And you need to remove, I like to remove as much of the uterus as I've caused trauma to by hand causing inflammation or tissue damage. But ovariectomy is also a totally legitimate technique. Unfortunately, that's not really what most people are doing in the United States or being taught in the United States. But I definitely encourage my students to use it as an alternative, especially when they have situations where they're not actually able to make it to the bifurcation without extending the length of their surgery or causing additional trauma or incision size for their animal. So that makes sense? And I'm happy to talk about that at length. I think that's a really good example of, but that's the way it's always been done.
Yeah, that was a great question. I'm actually glad that came up so soon because I was wondering if that was going to get
That's a great one.
So, yep, we've got a couple other people. We've got Brazil and Mexico also.
Nice, fantastic. I would love, I'm hoping to be on the front lines of changing that for you guys as well in the United States, but you know, you can only fight so many battles at once. So
excellent.
Great
follow-up question, Katie.
Yeah.
So it says, one person asked, I thought complete ovariohysterectomy was better for the future for potential neoplasia or pyometra prevention.
Okay, so what causes a pyometra, kids?
I'm watching.
Are there?
I have an estrogen, hormone,
no,
ovarian remnant, progesterone.
Progesterone.
Dinner, yeah, progesterone, absolutely.
So if you mess up and you leave a bit of an ovary inside of an animal, yes, there is an increased risk of pyometra in whatever uterine tissue is remaining in that animal. Otherwise, it would, if you didn't mess up, it would have to be an ectopic ovarian tissue, which is actually very rare. So as long as you're doing your part of the surgery correctly with getting the entire ovary out of there should be no increased risk of pyometra no matter how much of the uterus is left behind. Again, this is one of those, the way it's always done, and unfortunately we just don't have the science to back it up. Now there is exactly one case reported of a uterine adenocarcinoma in a uterine stump in a spayed animal. The animal was spayed later in life, so the uterus had been under hormone influence for a longer period of time, which probably led to the formation of that. But depending on the age that you're in the animal, there really, even with the uterus left in there, with the hormonal influence taken away, there should not be an increased risk of uterine adenocarcinoma there. Make sense?
Yes, we're good.
Okay, fantastic. Happy to answer any other questions that come up.
Awesome, thank you.
Moving on. Oh, there's some gravid uteruses. We've got like the cute little ping pongs on the left, and then this is a I'm gonna give birth soon on the right. Okay, now we're gonna move into categories of disease. I didn't include those ones in disease because that's just something you're gonna encounter. So we're gonna start with developmental. And so our most common developmental thing that we're going to run into is actually going to be in our boys, and that's going to be cryptorchidism. So that is a missing testicle, 1 or 2 missing testicles, right? So what do you guys think is the first thing we have to determine when we decide that an animal is missing a testicle?
I'm watching chat. I'm waiting.
Nobody knows.
Age, is it inguinal or abdominal? Where the testicle is, abdomen or closer to inguinal area. That seems to be the general consensus.
It is.
Yeah.
But in order to make sure that you're focusing your palpation accurately, I actually recommend that your first step is to decide, is it righty or is it lefty? Because if you know which side you're palpating for the testicle on, you're going to be more successful with palpation. So what you do is you push the testicle that is descended cranially in the inguinal canal, and should go to one side of the penis or the other. And which side it goes to is the side that it came from. Pretty easy, right? So once you've decided which side of the animal that descended testicle came from, then you can focus your palpation on the side where the testicle is missing. And then you're going to start working on, is it inguinal or do I need to go abdominal? And there's a structure in the inguinal area that can very commonly, especially in cats, be mistaken for a retained testicle. Anybody have any thoughts on what that might be?
Inguinal lymph node. I'm getting lots of lymph nodes.
Yes. But most animals should have bilateral inguinal lymph nodes. So if it's a little lump or bump that you're feeling on both sides when you're palpating and it feels, maybe they're not totally symmetrical, but similar, you have to be suspicious that that's actually a lymph node. Now, I'll be completely honest, I've gone after my fair share of lymph nodes, but and now if I think it's a lymph node, I actually go into the abdomen first instead. If you do go after lymph node, it's not the end of the world. Hopefully by the time you get down to the lymph node, you can realize that the tissues are not in any way testicular, and you don't have to actually remove it or traumatize it, and you can just kind of return it to its little home there. But beware, because they can feel a lot like a testicle. And a good way to determine, is this a lymph node or is this a testicle, is it moves as you're palpating it. If you have some cranial or caudal motion, or slipping cranially and caudally as palpating it, more likely to be a testicle, because even when it's retained, that testicle is generally still sliding in that inguinal canal, and it should be sliding cranially and caudally in that canal. If it's pretty well fixed into place, it's more likely to be a lymph node. And if it has a contralateral friend, it's probably a lymph node. Although you could get that bilateral cryptorchid, and then you might. If you have any doubts about whether you're feeling a testicle inguinally, it's always a good idea to go ahead and prep as if you have to go into the abdomen. And if you don't need to, great. But if you need to, then your animal's prepared for that, and you're prepared for that. And that's not something that you have to stop and take care of in the surgery. So if we're, I'm getting ahead of myself. Hang on. So failure to descend, we talked about that. Let's talk about age. So when you're seeing these animals, they're well puppy or well kitten exams. I'm about cat here this week, but I'll throw in the puppies too. Generally speaking, from the data that we've collected, if you're seeing that for its 8-week-old well kitten exam and that testicle hasn't descended yet, it's probably not going to come. You can definitely give it a chance and let it hang out there. I know that most of you in private practice aren't going to be performing neuters as young of age as we are in the shelter world. But you also don't want to give people too much false hope. I will also say, if you let the animal get a big old fat pad while you're waiting for that testicle you're going to make your surgery a lot harder on yourself as well. So I would still, in these male cats, recommend going after that testicle like by 6 months of age. And in pup, we can give them a little bit longer, but generally speaking, if it's not by 16 weeks of age, it's probably not. Maybe delaying this for other reasons that you've worked out with your client, but they need to be prepared for the fact that it's going to be a little bit of a treasure hunt. And then keep in mind when you're having owners, this is an inherited condition. Please encourage these owners to be neutering animals and getting these genetics out of the bloodline. The pig world is like horrible for neutering because cryptorchid puppy pigs have been reproducing all over the place, and now most of them are cryptorchid, and it's kind of horrifying. So let's make sure we're encouraging that not to happen in our companion animal populations as well. Okay. Okay, so surgical approach, if it's in the sub-Q in the inguinal area, we can just isolate the testicle right where it's lying, incise directly over it through the skin, and ligate the cords, bring it up of the canal, ligate the cords, and then close the tissues in usually 2 layers, sub-Q and then skin. This is a picture of the dog, obviously. An inguinal retained test of a dog, you can oftentimes push it over to the precordial midline, and you can oftentimes get both of your testicles out through the same incision. Not always, sometimes they're more fixed in place and the distance is too far, but that's definitely something that I've been able to do many times. And then if it's abdominal, we have to remember anatomy. And anytime we're performing surgery, we should know what kind of anatomy we're going to be using and encountering. And it's really important in this procedure because we have to remember the course that the testy travels during development, where it started and where we expect it to be, because it's stuck somewhere along the way. So we have to use that knowledge to figure out where we need to check. If we're going to be going into the abdomen, we're going to make a caudal midline incision for cats. If we have a dog, we have to work around that annoying prepuce to make a parapreputial incision. And you can either enter through the median incision or you can enter through the linea. That's the preputial approach. I like to enter the linea. It doesn't mean that you have to dissect under the penis, but it means that you're not cutting through muscle, which can be oozy and annoying. And possibly more painful for your animal, for your patient. If you dissect underneath the penis to get to the line, make sure you put it back on straight. When I'm in the abdomen, I start with a very small incision in the caudal, and I actually use my hook first because I can use my spay hook following the same course I would looking for uterine horn. And if I've got a ductus deferens or a vascular pedicle traveling that course along that way, I may be able to hook it just through with my spay hook through a small incision, bring it up to the incision, and take care of my ligations. Now, when we use that technique, or when we're working with the abdominal testy, it is really, really important to remember, I don't know if I have like a pointer here. I don't think I do. On the picture on the right, can you guys appreciate that before the testicle passes through the inguinal ring and into the, and down towards the scrotum, that the vas deferens and the blood supply are 2 separate structures. So when you're bringing that abdominal testy up to your incision, you have 2 structures that you need to ligate. And depending on how it is lying developmentally, you might be able to bring them together to ligate them, or they might be kind of coming from diverging sides, and you may actually have to ligate them kind of individually before you remove the testicular tissue. And obviously the epididymis. And it's going to look really different because it's not in that vaginal tunic that we're used to seeing it in. It's going to be kind of separate and loosey-goosey, so make sure you get all of it and that you know what you're looking at. In the cat, I don't really encounter the gubernaculum as a distinct structure very often, but sometimes in the dog and the abdominal testicle, I do. And sometimes that can actually be kind of vascular as well, so I usually ligate that. If our spay hook trick didn't work, our next step is to make an incision that's long enough that we can retroflex the bladder. So flip the bladder up and caudally so that we can look underneath it. And so the picture on the left is what we're looking at when we retroflex the bladder and we're looking for our structures. And the structure we need to find in order to follow to the testy is the vas deferens. And it's really, really important that you can identify the ureter implanting on the trigone, and then you can find the vas deferens looping around it. And there's usually going to be some fat here because there's a kind of a fatty genitourinary fold that runs along the dorsal surface with the ureter and comes up and implants on the bladder there. And you want to make sure you're following the correct side, right? Because we have 2 vas deferens, and one is going to be going to the descended testy and one is going to be going to the retained testy. Really, really important. You need to follow the vas deferens in the correct direction. That is away from the bladder and towards the testy. There are case reports time and time again of surgeons, veterinary surgeons, removing the prostate. And that is really serious because when you remove the prostate, you remove a piece of the urethra. And that is not something that you're going to be able to fix yourself in your clinic. And that is something that is going to be life-threatening for that animal and potentially not fixable at all. So you really, really need to know this anatomy, and you need to, if you're not familiar with it, review it before you go in for these surgeries. As a fun exercise, I encourage beginning surgeons when they are in abdomens and they're looking at bladders and they're deep enough in the abdomen to just take a little time to check out your friend the ureter and follow it around and see where it lives, so that you know how to avoid it. Okay. Any other questions here?
Don't see any questions popping up so far. You're doing good.
Cool. I will say I had just recently my very first true monorchid. And so this is a very rare condition. There are a lot of other reasons that your testy might be microscopic or traumatically removed or otherwise missing. But this animal did not have a second vas deferens, and it did not have a second testy. It was very strange, but it can happen. But from looking at the case reports, very rare. So make sure you're looking around. And if you do find anything attached to the end of a vas deferens anywhere, whether that's inguinal, by the scrotum, in the abdomen, make sure to remove the end of that vas deferens and those tissues. If you want, you can send them out. You can offer to send them out for histo to confirm whether or not there's microscopic testicular tissue there, because there can definitely be some weird developmental things where you might not really be able to visualize testicular tissue. Right. In the girls, kind of a similar issue, similar but different, is our uterus unicornis. So in this surgery, you've taken care of side one and you're cruising on down towards the bifurcation, and there's no bifurcation. Where's the other side? Where did it go? Why can't I find it? So in this case, you've probably extended your incision at this point to get good visualization. You might be underneath the bladder in that same area where we were looking for the vas deferens. And then you're gonna wanna look for that genitourinary fold on the contralateral side, which is gonna be that fatty fold that the ureter is running in the retroperitoneal space up on the dorsal surface of the animal. Even if there's no horn, there's still gonna be a fold there, and there may be a little sort of shred or vestigial mesometrium attached to it. And you need to make sure you follow that all the way back up to the kidney, because you can have a missing horn, you can have a hypoplastic horn, but either way, you could have an ovary present there, even if you don't have a horn. And if you don't check for the ovary and don't remove it if it's there, you're gonna have an angry client, because you're gonna have a cat that goes back into heat after surgery, and they're gonna come back to you and they're not gonna be happy. So always, always, always check for the ovary, even if there's something weird going on with the horn. And then the other thing that you want to keep in mind is the developmental connection between our genitourinary tract. So if you have an abnormality that you are appreciating this could be a cryptorchid, a monorchid, or a uterus unicornis, definitely make sure that you check and see if the kidney is present on that same side. I have had different combinations of yes ovary, yes kidney, yes ovary, no kidney, no ovary, no kidney. So it could be any of those situations. And if you only have a cat with one kidney, that's probably something that you are going to want to know about going forward, and your owner's going to want to know about going forward, so that you can take the very best care of that kidney. Interestingly, also could happen with the monorchid, but he was a lucky boy. He had 2 kidneys. Remember your anatomical retractors when you're in there. If you're having a hard time finding that genitourinary fold that we discussed, you can use your descending duodenum and your descending colon, and that will lead you down to those genitourinary folds to the area where you would be looking for any evidence of ovarian tissue. Okay. Last developmental thing is hermaphrodism. So if you guys remember, a true hermaphrodite has to have both ovarian and testicular tissue present. And it might be the same gonad, ovotesty, or could have one of each, mixed bag. What that does is it results in concentrations of hormones that are abnormal during development, and then some sort of change in the appearance and structure of the genitourinary tract, either internally or externally. The most common presentation you're going to run into is an animal that looks female, maybe has some sort of enlarged clitoris kind of situation going on the back, might even look a little bit like a prepuce. But then the surgery itself usually proceeds pretty normally because the changes are actually on a microscopic level. If you decide to submit it for histopath, the pathologists are going to love you because they don't get this stuff very often. They get really excited about it. Think about your other differentials though when you're running into strange anatomy during your physical exam on your animals pre-op. I have run into cases of low-grade atresia ani. So even if your atresia ani congenital defect doesn't cause an absence of a rectum, it may cause a connection between your urethra and your rectum, and that can present with some strange external genitalia. I've seen this in 2 male cats. One was a young cat, and they thought it was a girl because it looked like it had a little vulva. And then went in for surgery. There was no uterus, went back on the outside. There was some testes that were kind of hiding in the perineum. And this cat actually was pretty young, and it was being monitored post-op and discovered that it was having problems with defecation as well. And in treating it for constipation, discovered that its little vulva was actually a blind-ended pouch and that its urine was coming out through its rectum. And so the urethra was emptying into the rectum. And unfortunately, that resulted in ascending infection and a poor prognosis for that little buddy. Pseudohermaphrodism means that your ovarian and testicular, your tissues are normal, but your outside looks abnormal because you've had some sort of imbalance of hormones during development at a critical time when those tissues were developing. And then chimera, that's another possibility. Okay, we're moving on to infectious. What do you guys think the most common infectious thing is we're gonna deal with?
Pio. I'm getting a couple.
Pio. Yeah. Progesterone. I already asked that question, so I don't get to ask it now.
I'm just gonna be chanting progesterone for the rest of the day. Yeah. It looks like I'm getting pretty much all pios.
Heck yeah, that's the answer. So cats can be really sneaky with their pios. In particular, you can go into a surgery not expecting anything abnormal at all and get in there and you've got a hot mess. They're very fastidious. So even if they are producing discharge, you might not be able to pick up on it. The owner might not have picked up on it. The cat might be in good condition otherwise. Sometimes they're not so much, but a closed pio would present the same way as it would in a dog, though, with an animal that is not doing well. PUPD, inappetence, depression, all of those clinical findings. If you had an animal that was unstable, you would want to try and stabilize as much as possible prior to surgery, but keeping in mind that a closed pio, especially with your diagnostics, if you're finding a very large distended uterus, that's not a surgery that you want to delay because of the potential for rupture. You want to get some antibiotics on board. E. coli is one of our most common, or other GI bugs, one of our most common ascending infections there for bacterial pio. And then we're going to talk about some techniques for that. Keep in mind that all pyometras start as endometrial hyperplasia. So progesterone is having a party and it doesn't want to stop. And so the endometrium starts getting bigger and bigger. And you may have a uterus that is enlarged, that is thickened, that has increased vascularity, and it might not be a pio yet. It might be endometrial hyperplasia. And honestly, you probably aren't going to know until you get that uterus out of there and maybe look at a cytology from what's inside of the uterus. That endometrial hyperplasia can then either resolve on its own, or it can progress into hydrometria, which is when the uterine horns fill with kind of a watery fluid, mucometria, when they fill up with like mucus, pretty gross, or pyometria, that either sterile, which basically means it's filled up with a bunch of sterile fluid and gunk, or ascending infection and then bacterial pyometria. And those are the animals that are going to be sick. All of the other conditions, they're probably not going to feel all that badly, but you are still going to have to deal with some enlarged tissues, some tissues that are under hormonal influence, and some enlarged vasculature. When you get that uterus up out of there, you're going to make sure you pack off that uterine stump really well with your lap sponges before you do any cutting. And this is a case where we do want to place a clamp on the uterine body. We need to be a little bit careful about the size of the tissues and the strength of the tissues and make sure we choose a clamp accordingly. This might not be the time to pull out your little mosquito hemostat. You might need to get out your big old Carmelt for this to make sure it doesn't slice through those tissues. But you don't want that material from inside the uterus ending up back in your incision when you remove the uterus. So make sure that you're definitely clamping that off for backflow. I also, after I've removed the bulk of the uterus and I'm working on the stump, I make sure to clean it really well, get some saline in there. If you have suction, you can do your full filler up, suck it out. I've never worked in that fancy of a practice, but that's a great idea if you have the tools available to you. At the very least, you need to get some saline in there somehow and be cleaning stuff up before you put it back in the abdomen to prevent contamination. And then they used to recommend over sewing of the uterine stump for pyometras, but we figured out that that was really just dragging suture through contaminated tissues and then kind of spreading it around. So my preferred approach for these is an encircling ligature, as tight as I can get it without tearing through the tissue, and then those individual transfixations. And the transfixation shouldn't be going into the lumen of the uterus. It should be transfixing onto the muscular layer of the uterine body, and then just coming around those middle uterine artery and vein bundles individually. And the reason for that is I don't love the idea of having a big old wad of infected tissue and then trapping it between two encircling ligatures and then leaving basically like an abscess in there to kind of keep brewing and stewing while things are necrosing. You could do that. I'm sure there's lots of people who do that. I personally am just not super comfortable with it. Got a cool radiograph of a big meaty uterus hanging out between a colon and a bladder. Obviously we're all using ultrasound, or most of us are using ultrasound nowadays anyways, so you would probably be able to ultrasound if you had a suspicion about pyo and find like a big viscous organ where it shouldn't be. And obviously that poor kitty on the right didn't make it, but I think it's a good example that cats are really good at hiding things, and so you can have some pretty major surprises when you get in there for surgery sometimes. Okay, don't forget about the boys. Prostatic disease. I don't know if cats really get prostatic disease. Anybody seen it? I haven't. This is obviously a talk for dogs and cats. I can skim over it, but basically if you're dealing with prostatic disease, you're going to want to recommend castration because you have to rule out benign prostatic hypertrophy, and castration is a good time to get more samples if you're concerned about other issues going on in there. Maybe you've got some imaging already that leads you to believe there could be something more serious going on, and you might be able to get additional sampling done at the time of the procedure. If you're treating with a bacterial prostatitis, you want to make sure you choose an antibiotic that actually penetrates, and it's not going to be like a UTI where you treat it for 7, 10, 14 days. In order to really get into that prostate and fully treat that, you're going to want to be treating for like 6 to 8 weeks minimum, and if at all possible, following up with culture. Okay, moving on. Trauma. You guys in private practice might not see trauma the same way that I see it as a shelter veterinarian, but it's always good to know what kinds of things you might run into, because you may be seeing some feral cats from your community, or have some cat aficionados that are helping out feral cat populations, and they can just have some really weird things happen to them. And they're really good at hiding it, like I said. So the most common thing you would encounter is evidence of uterine rupture, and that can happen usually when an animal is pregnant and then has some sort of penetrating trauma or increased abdominal injury that causes increased abdominal pressure that can rupture the uterus. And that can actually push the fetuses out into the abdomen, and then they sort of form adhesions. You could have mummified fetuses that are kind of like hanging out in the abdomen. And you might be able to appreciate that on your pre-op exam, or if you're doing radiographs for some reason, you might see little skeletons in there. But if they were not that far along to have ossification, you might not see that. If you did encounter that, you would just dissect them on out, make a big incision, make sure you're visualizing everything, make sure you know what it's attached to, that you're not dissecting through mesentery or something like that, and get those little foreign materials out of there. Testicular trauma, I see this more in dogs than cats, but certainly if you have a testicle that is a different size, feels different on palpation, or could be a DDX for a cryptorchid, some kind of trauma instead of a congenital issue. Those testes are susceptible to a wide variety of things. Anytime you're running into some weird with the testes, I would recommend keeping both of the testes and recommending histopath for the owner, because you have to keep neoplasia on your list for weird things in the testes as well. Okay. This is a cool case I found of uterine trauma that I think really highlights how fecund cats are. So this was a cat that was presenting for a regular spay, and they went in there and they found a pregnant uterus with a viable pregnancy. That's the small uterus on the bottom right. And then the little circle is showing you where there was an adhesion. And so when they found the adhesion, they thought, oh, well, maybe we'll just explore this a little more. And they pulled out all of these fetuses that had been pushed out from a uterine rupture and were hanging out in the abdomen. And yet the cat had managed to heal up its uterus and become pregnant again. So this is why cats have an overpopulation problem in the wild, and why we need to spay them. So if you see something
like cats are weird aliens, like I don't.
They are. They're totally aliens, and they will survive. We don't need to help them. So if you do encounter any kind of weird adhesions as you're approaching a uterus or ovaries, it's definitely a time to take a better look around and see what else is going on, because you never know what you're going to find. Okay, I'm going to talk about neoplasia here for a second. And my disclaimer is that I am in no way an oncologist, so I'm sure all of you know way more about cancer than I do, but I'm just going to touch on it real quick. So anytime you find a lump or bump while you're performing a spay or neuter, take the tissues, recommend histopath. If you're if it's a spay, include the ovaries for a uterine mass, because the pathologists are going to kind of want to know what's going on hormonally. And then entire uterus and ovaries if possible. And then if you're submitting a testicle, make sure to include the regular one too. They like to have that for control, for comparison. And our differentials for our lumps and bumps in here are going to be a benign or malignant tumor. Cysts I see pretty commonly. You can find abscesses like from previous injuries, or like a seeded infection of some sort, fibrosis, trauma. And the cysts, I've been really surprised. They can occur at any age. I've had literally like 8-week-old kittens that have giant cysts on their oviducts or ovaries when they go to spay them. So not necessarily hormonally dependent. And if you're ever having a hard time bringing an ovary up to an incision, go ahead and take a feel in there, because you might have a giant cyst attached to it. And ideally you want to keep that intact and not pop it while you're getting it out of there. And then when we're working in the uterus, our most common benign tumor we're going to encounter are those smooth leiomyomas. They usually look kind of friendly, but they still have a mass effect. You still want to get them out of there and submit for histopath. Our angry friend on the uterus is going to be the uterine adenocarcinoma most commonly. Again, other than the one case report of a uterine stump with an adenocarcinoma, pretty much 100%, 99.999% prevented by spaying our companion animals. And in rabbits, unfortunately, probably because they don't get spayed at an early age as often as our other companion animals, we see them in up to 60% of females will develop these over the course of their life, especially if they're over 3 years of age. So if you end up in a situation where you're spaying a lot of rabbits, definitely keep your eyes open for this. If you're seeing abnormalities in the uterus, so try to recommend submitting those tissues, because that might kind of change the treatment plan and management plan for that rabbit. Sorry, I just had to throw some rabbits in cat class. And then in our ovaries, if we've got lumps or bumps there, we need to be thinking about our carcinomas. Might produce hormones, so you might be seeing effects from that, but might not. And then in our testicles, we've got our 3 types, right? Our Sertoli, interstitial or Leydig cells, and our seminomas. In dogs, interesting, I thought that 1/3 of dogs with one of these tumors will have more than one type present. Seems like a little bit of an overachiever. And then keep in mind, as we talked about before, I forgot to say this before, but the retained testicles are at increased risk for neoplasia. So that's another reason to really try to encourage those owners to neuter those cryptorchid dogs and cats. Got a couple little pictures here for you. I've got the rabbit uterus on the left there. I could give a whole nother lecture on rabbit spaying, but I won't. And you can see the area that the arrow is pointing to. You've got the nice smooth uteruses. Remember, they have 2 uteruses attaching at 2 cervices. And you've got this area that looks red, it looks angry, it looks enlarged, it looks vascular. Especially with a rabbit, it's most likely going to be a uterine adenocarcinoma. And then in the middle, we have our smooth, friendly leiomyoma. Doesn't look as scary, does it? But we still want to take it out of there. And then I'll be completely honest, I don't remember which tumor it was in the testicle. I just thought it was a cool picture. It's one of the 3. If you are performing mammary neoplasia, I know it's not spays and neuters, but if you are performing spays on older animals, you're going to run into mammary masses a lot of times during that procedure, and they might be benign, they might be mammary hyperplasia or something like that. But in our kitty friends, if we're finding masses in the mammary glands, definitely try to recommend that metastatic workup before you take them to surgery, because 90% of those mammary tumors are going to be malignant in our kitty friends. And it's a pretty major surgery. I don't know if as students, if you've had a chance to be involved with a mastectomy yet, but it's pretty intense for the surgeon and for the patient and for the owner with recovery and everything. And so depending on your prognosis from your metastatic workup, you have to make sure that everybody's on board for going ahead with that kind of treatment. And if you're testing lymph nodes, just a little diagram to remind you where to check lymph nodes depending on where you're finding those masses. We've got our inguinal for our last 3 mammary glands and our axillary lymph node for our first 2 mammary glands. If you were going to do both of those things at the same time, a spay and taking care of some mammary masses, which in the shelter world we do, you would want to make sure to do the spay completely, close up the linea before you touch any kind of potential tumor tissue, because you don't want to be seeding any kind of tumor tissue into the abdomen, of course. And I'm not going to talk about this today, but if Dr. Marshall lets me, I've got a great presentation that's all about things that we do in surgery and how to deal with those. So stay tuned, perhaps. But that's all I've got. Does anybody have more questions?
It looks like, okay, so I have one here. So going back to ovariohysterectomy, ovariectomy, if we want to do more ovariectomy in general practice in the US, should we be giving both options to clients?
Ooh, that's a great question. I'm interested to hear what other veterinarians think about that. I think that you could offer both options. I mean, at the end of the day, for me, I make the decision based on my efficiency and reduction of tissue trauma to my animals. So it's a decision that I oftentimes make in surgery. So if I've gotten my first ovary and my first uterine horn and I can't get to the bifurcation without extending my incision and extending the surgical time and tissue trauma for that patient, I take my spay hook and I grab the horn on the other side and I grab the ovary on the other side, and then I just ligate each horn individually. And it turns into an ovariectomy because it saves time and it saves comfort for the patient. But a lot of times I can make it to the bifurcation and make it over to the other ovary without extending my incision. And in those cases, my approach is, well, I'm already here. So I usually go ahead and perform the ovariohysterectomy, but interested to hear if anybody has a different approach.
I think it kind of depends on what's available to you too. I know some general practices have laparoscopic equipment. I know Mel was just asking if anybody's doing laparoscopy. I don't at my clinic, so I've never done one, but I know I have friends in the UK since my fiance is British, and so we have tons of vet friends in the UK because we're both veterinarians, and I know that their hospitals all have laparoscopic equipment, so they're offering it to clients now. They do laparoscopic ovariectomies at the specialty hospital up the street from me, so I offer it to people. I think it's a good conversation to have, but I don't know how common it is that people are doing that. So I don't know how accessible it is. So
yeah, no, I think if it's accessible, you can definitely offer it. The way I look at it is my incision size is pretty much the same as laparoscopic, and I can do it in about 5 minutes. So that's probably what I'm going to offer my patient.
Yeah, absolutely. I think time and patient, like I said, tissue trauma to the patient is what's going to be big. There's another question on autoligation.
Yeah, sorry, I totally left that out. Oh no.
I also, if anybody wants, I have a couple really good videos, and Dr. K might have some too, but I've got some pretty good videos of a gal doing both canine and feline castration and spay, as well as with autoligations on cats, and she also does a flank spay with autoligation. So if you guys want those, go ahead and DM me at vet_redefined if you want me to send you those. I'm happy to send you the links. They're pretty good videos, so I can send those to you if you guys would like to watch. They're like right up in there too, so you can really see what she's doing.
Yeah, the ASPCA Spay Neuter Alliance also has a lot of good videos about autoligation techniques. I don't think they have a flank spay one though. I'll have to get that video from you. That sounds great.
It's really good. And then ASPCA Pro has a lot of good videos also.
Yeah, that's the same.
Another good place to go. But yeah, so she says, thoughts on pedicle autoligation?
I love it. I usually encourage students to work up to it over the course of their rotation with me. A lot of times they don't want to start with it, and I get that. You want to make sure you're good at ligating things too. Even as a high volume surgeon, I still have cases where I take a look at a pedicle and I'm like, I'm not auto-ligating that. I'm going to throw a regular ligature on it. And so it's really about making choices for each individual patient as an individual that keeps them safe and comfortable.
Yeah, awesome. And then I've got another question here as well. It looks like it says, are you only concerned about tissue trauma and extended surgery time, or are there other pros for performing ovariectomy versus ovariohysterectomy?
These are the two I can think of. Anybody else?
I mean, I think tissue trauma and time is a big one. But also, I think a lot of people forget about the hormone aspect of the neoplasia and pyometra thing. If you're removing the whole ovary, you should not, in theory, be predisposing the patient to developing those diseases afterwards. So I think oftentimes we forget about that.
Yeah.
I don't see anything else. Any other questions? This one says, we learned that the patients heal faster after ovariectomy versus ovariohysterectomy.
That would be a cool, do we have any research that's been done to look at side by side, like same surgeon, 2 different procedures, pain scoring after, and that kind of thing? That would be interesting. I know they've done that for scrotal and prescrotal castrations, but I don't know that I am aware of a study with OVH versus ovariectomy.
Yeah, that one I'm not sure. So I think that that's something that I would have to look at and dig around for.
Cool.
We should do one.
Let's do it.
Good stuff.
I don't know. I don't have any more questions popping up right now. I know we have a couple little housekeeping things that we wanted to run through at the end quickly before everybody jumps off. I think some people are kind of already heading out, but I know Dr. Marshall mentioned at the beginning, don't forget tomorrow we were talking about eyeballs. Dr. Crystal Bowles will be talking about eyes. So if you don't want to miss that, I, for one, definitely did not get enough ophthalmology in school. I didn't even get to take my ophtho rotation because it was on a lottery basis, and I just wasn't one of the lucky winners who got ophtho. So absolutely, eyeballs tomorrow.
That's great. Good job, you guys. Sorry I wasn't there with you the whole time. Too much multitasking, but I have recorded this, and I'm definitely going to play it back to myself later, and we'll figure out where we put these as time goes by.
Yeah, absolutely. I'm getting a lot of thank yous in the comment box, Katie. So everybody's like, yeah. Also, if anybody happened to record the hyperthyroid lecture on Monday, if you want to let me know, that would be great. Because I think we had some technical difficulties, like maybe we thought we were recording, but we weren't. So if anybody did record that, like on your phone or on video or screen share or whatever, if you could let either myself or Dr. Marshall know, that would be awesome. But yes, we will find a place to post all of these for you guys. So.
Somebody said that Jackie has a question. Is that true, Jackie?
Did I miss one? Sorry, Jackie. Oh, she says, are there any good resources to talk about this? I could see it being hard to convince older veterinarians to let me only remove the ovaries. So just
Are you talking about me, Jackie?
Yes. Yes, old man.
I was trained by somebody who graduated in 1950, so
I was trying to type really fast to get the question on there. That was the best way I could put it.
That's a really, I bet there's like an info sheet or something. Let me do a little digging and see if I can find you something.
Thank you.
Otherwise, you can just give them my phone number.
Awesome. All right. Any more questions, you guys? I don't see anything else popping up. I think people are slowly starting to filter out.
Okay.
Cool. Thanks, everybody.
Good job, you guys.